As with all measurements, when we make an ECG measurement, there are obviously things that can go wrong. And it's particularly significant if you're in an ER environment or another diagnostic environment where critical healthcare decisions are being made, that the measurements that come in are accurate and trustworthy. So in the next few slides and in this short video, we'll talk about what are some of the things that can go wrong with an ECG measurement and how we can possibly mitigate those. So the first thing that's shown here in this figure is the effect of a voltage transient on an ECG. And in this case, the voltage transient was quite large, so large that it caused the amplifier to saturate. So you can see that first the amplifier saturated in the negative direction and then in the positive direction, a little bit of a squiggle here. Then it saturates again in the negative direction. And then you notice at this point we begin again, and we don't see the ECG signal here because clearly the voltage in the transient is so large that it exceeds any range of the ECG. Now then, at some point, we note that the ECG signal shows back up, and over the course of several heartbeats, it comes back to a zero baseline. So what's happening here is that amplifiers all have certain time constants associated with them. And normally when we design an amplifier, we design it to operate in the linear range where the amplifier does not reach saturation. So oftentimes these internal capacitances and time constants associated with an amplifier, particularly an op-amp, are not necessarily obvious to the user. At this point, what has happened is the amplifier has been driven into saturation, and so there is a recovery time associated with bleeding off all that excess voltage to get the ECG back into that active region of operation. We see this in the EEG lab all the time. Usually in the EEG lab, the response time of the amplifiers is faster compared to what you see here, but the saturation is occurring because of some external source. Often maybe a person sneezes, or they clench their teeth, or they generate some really high signal that drives those amplifiers into saturation. The problem with obviously making the amplifier less sensitive, so that are using some kind of voltage divider prior to input, is that while you may reduce the input voltage of your transient, you also reduce the input voltage of your actual signal. So there's a sensitivity trade-off there that if you amplify too much, you get these transients being greatly amplified. If you don't amplify enough, you can't resolve enough of your actual signal. So this is what's referred to as the first order kind of recovery of the system, meaning that the system, when in saturation, can be modeled as like an RC circuit that then bleeds voltage off the capacitor and restores the operation of the system. This is an example, two different examples. The top example, figure A, shows what it looks like when we have interference from a 60 hertz power line, and you can see that that's most obvious on the lower frequency portions of the signal. And then this bottom trace illustrates what happens when we have EMG interference. So remember, EMG is your muscle signature. It tends to be significantly higher frequency than most regions of the ECG. But note that if we were to filter out some of this noise, we would lose part of this more rapidly changing part of the QRS complex in the ECG. So that also is a trade-off when using filtering, being able to get rid of this noisy EMG interference while also maintaining your clean QRS wave. The best way to deal with this interference is to prevent it from happening at all. So on the 60 hertz, isolation of your system, removal from proximity to any high power sources, and that's often easier said than done. You can sometimes use a specific 60 hertz notch filter to get rid of this. EMG, one of the best things you can do is obviously advise the patient to be as still as possible, even at times perhaps holding their breath for a brief period of time. And also check your leads and be sure that the leads are tight, that they're not slipping around, because that gives a signature sort of like an EMG, keeping the patient relaxed, things like that. Here's an example of how you can pick up 60 hertz noise from a power line. Usually the issue with power lines is capacitive coupling. So here would be your ECG measurement system. Here's your right leg that's connected to a common ground. If you are capacitively coupled, then what happens is you have these virtual capacitors that appear between the power line and the leads, and this causes what's referred to as a displacement current. The displacement current enters the body and then gets picked up on the ground electrode, and that causes basically the 60 hertz noise to appear. This is just a sort of a back of the envelope kind of calculation that your author did that shows that this level of this kind of noise can be about 120 microvolts. A lot of sort of license taken with these calculations in this simulation, but this is not an unrealistic number for certain 60 hertz noise. There's also capacitive coupling that can occur between the power line and the body itself. So this illustrates capacitive coupling between the power line and, say, in this case, just illustrating top of the head, just to show that displacement current here can flow through the body. It appears in a slightly different way because basically it will flow through the body to ground, through that right leg grounding wire, and then appear as a voltage on the input of the differential amplifier. And it appears only on the ground input, so it's not a common mode kind of noise, which means it can basically create issues. You also have some resistive elements between the body and the amplifier, some of which are just a part of the wiring of the system that also enter into this noise calculation. And so you can see here, coupling between power lines and the body itself can be on the order of 40 microvolts. You can also pick up voltages inductively. So if you have power lines in the vicinity, that can generate a magnetic field that can be non-negligible. Remember that inductive pickup is an enclosed time-varying magnetic field. So if this is a 60 hertz field due to the presence of wiring, and you have your leads arranged in such a way, and you count your body as part of the circuit, then there's this large area that encloses this time-varying B field, meaning that you pick up a non-negligible current that's induced from this electromagnetic field. If you do clever things like twist your wire leads, then what that does is A, it minimizes the area enclosed, but B, because of the direction of the current flow in the wires and the fact that one loop goes one way and the next loop goes the other way, you basically have a canceling effect. So there's a positive, negative induced voltage in each of these little loops, and it minimizes then the total amount. Also, keeping the leads close to the body is another way to minimize that. This is an example of some other things that can go wrong. This would be a situation where you have an overvoltage on your leads. This is to protect the machine. So you saw the illustration of the saturation of the amplifier. So this would be an example where perhaps you have some high transient voltage. Classic case would be if you're using a defibrillator circuit on the patient That's not going to harm the patient. Hopefully, it's going to save the patient's life, but it could very well harm your ECG preamplifier because the voltages are so high. So you have then, as the leads come into the preamplifier lead selector, and the right leg lead comes in as the reference ground, you have between the leads and the ground an overvoltage protection scheme. Basically, these are switches that activate when the voltage exceeds a certain level, and when the voltage exceeds a certain level, then they effectively short to ground. Typically, these would be a xenon diode, which basically provides a short when the voltage exceeds a preset amount in either direction. You usually use, sometimes you will use back-to-back diodes, other times you'll use a breakdown Zener diode that has it's just a voltage limiting kind of circuit. And so this will limit the voltage in one direction, this limits the voltage in the other direction, so that either a high or a low, or either a positive or a negative voltage at a certain threshold, this looks like a short. A gas discharge tube, not too commonly used anymore, but at one time, if you have very, very high voltages, this is a way to limit that. And the advantage of the high voltage breakdown tube, first of all, it allows higher voltages, but secondly, a lot of times diodes in solid state circuitry can be destroyed if the voltage is too high. The gas discharge tube, that's usually not the case. You usually have a pretty stable mechanical system here. Here's an example of sort of what the common biopotential ranges are in frequency and voltage. So let's find 60 hertz. That's going to be about here. Remember, this is a log scale, so 60 hertz will be about here. So notice that 60 hertz noise is actually going to overlap the frequency range of the EEG, the ECG, and the EMG. So all of the three biopotentials that are the ones we're typically concerned about, 60 hertz noise is a part of there's a 60 hertz part of the signal spectrum as well. So trying to filter out the 60 hertz noise, the bottom line is that can impact the measurement you actually make. The ranges for the potentials of the outputs here, you notice that the ECG ranges from the tens of microvolts up to the tens of millivolts. Remember, those noise levels from capacitive coupling were in the 40 to 120 microvolt level. So at the lower voltage end of the signal range, you would expect that could have an impact. There are things you can do in a clinical environment that would be not unlike what you would do in a research lab, where you can provide certain grounding and shielding. You can provide ground planes that give you some isolation from this capacitive coupling. The issue is that in the clinical environment, you typically, not only do you have power lines in the environment, you often will have a significant amount of equipment, and that equipment is powered by 60 hertz, and it's very difficult in a crisis situation to actually isolate all of that as far as capacitive coupling. So that can be a challenge in an ER type or critical care type environment. So that concludes talking a little bit about what kinds of signals can occur that give you problems. There are some safety considerations that you can also talk about, and I'm not sure, let me see. Here is a little bit of a block diagram of a signal that's used with a cardiac monitor, and it shows some of the protective circuits. So you can see Here's your kind of your over voltage protection between the two different electrodes. You have a low pass filter, you have a band pass filter. Um, what you're doing here is you're detecting some kind of a threshold that says if you've gotten if your electrode impedance is too great, or one of your wires suddenly comes loose, so maybe one of your electrodes comes off, it's not making good contact anymore. You're doing a little bit of a threshold detection. In other words, make sure I have a certain voltage threshold. If you fall below that, then an alarm is triggered that tells the person who is watching the monitoring system that they need to go check the leads, check the wires, make sure everything is still adequate. So this is done in a separate sort of parallel circuit to the actual amplifier. The other thing a person could do is do this detection on the amplifier. If you do the detection on the amplifier, you're picking up both the possibility that you have a lead failure as well as the possibility that your heart rate voltage has dropped. So you don't know, if you're doing your detection at the amplifier level, you don't know if it's a lead problem or if it's a patient problem. So that's why it's important to have a separate and independent circuit that does the detection of the lead stability so that you know it's a lead problem, not a patient problem. The disadvantage of that obviously is a psychological one, that the people monitoring the patient are very busy. They often have multiple patients. If they see that it's clearly a lead failure, I've seen them before just go hit the reset button on the machine and go on about their duties without actually going and checking on the patient. And so that's not anything anybody ever intends to do. But if you know you have a lead failure detection circuit, it's an easy thing to do when you're extremely busy. So that would be the one disadvantage, but lots of advantages to doing that. Here is an example of an ECG that looks distorted. You can see we've got a little bit of an odd kind of shape. This is tilted backward. We've got some extra bumps in here. This is due to an instrumentation problem. And so, as we've discussed, there could be several things. There could be loose leads, there could be capacitive coupling, there could be any number of things that could be going on to make this happen. Even a lead misplacement could be a possibility. So usually the machine will tell you that your ECG is abnormal, and before making any conclusions, the person administering the ECG should always check and see if there was some potential cause for the distortion that was part of instrument or user. Here's what it looks like when you just look at lead pair 1 and lead pair 2, and this looks obviously nothing like the ECG that we're used to. So basically just an illustration of the need for multiple locations in order to do this kind of vector manipulation to actually detect the heart rate. So that really concludes the discussion on the ECG, which really is the only measurement that's covered in detail in Chapter 6 of your textbook.